Hello, I'm James Cullis, and I'm going to show you some diagrams and some images of the female pelvic floor, some of the defects that can occur, as well as incontinence and some of the treatments available, and introduce an implant that I have come up with that I think is a great idea for the future. So basically, this is a small model of the pelvis, a miniature version. Basically, all the muscles have been taken out. So this is looking at the pelvis, and the lady's feet's down here and her head's here. This is inside the pelvis looking down, similar to this picture up here. Pubic bone. Basically, we have a bladder, the urethra, and this is the fascia, or the supportive elements of the floor, almost like a bowl. Here it shows the same thing, urethra and bladder. Key notes is this piece of tissue here is a condensation of a bunch of fascial tissue. It's in this line here on this picture. It's in this line, this picture here. It's called the arcus tendinus. You can see it in this picture right here. It's showing it right here. These are very dense structures and key points for doing some sort of reconstructive surgery of the pelvis. So basically, you have a urethra here, and this is about 2 centimeters before the bladder starts. So a surgeon, historically, when they did a so-called bladder tack, they entered inside the female pelvis surgically with an open incision and went straight down to the urethra, right down to this spot here. They pulled all this off of the pubic bone. And they're basically looking at this diagram here. The classic and the most popular for a retropubic suspension was what was called a birch, or urethropexy. It has different names, and all it was basically the surgeon placed 4 different suture bridges between Cooper's ligament on the top of the pelvic bone to this fascia lateral to the urethra, sometimes called different names, sometimes called the urethral pelvic ligament, pubocervical fascia. On this pelvis here, you see that I've put some material here to show the Cooper's ligament, which spans the top border of this pubic bone. And then these would be 4 potential holes that basically a stitch would go through there and pull back up to here, giving 4 suture bridges. And why would you do that? In order to treat hypermobility of the pelvis. This is a loose demonstration of a pelvis. This patient, this model, has hypermobility. You want to elevate it, such as this, and fix it so that there is no hypermobility to keep a lady from having stress urinary incontinence. Is what you see here. This is post-surgery. This pelvic floor is pulled up around the periurethral area to prevent hypermobility. Basically, you could have other lateral defects. Here's the bladder, here's the urethra. These are tears, or you could have laxity, and these can be repaired at the same time in surgery in a retropubic approach. Retropubic coming in this way. This can be done robotically or open. And basically, here's a demonstration of a surgeon doing this type of surgery. Basically, this is the pelvis. That's the pelvis. This is hard to see. The surgeon is going to place 2 fingers in the vagina, which is right underneath this pubic bone. You urinate right underneath the pubic bone and put your 2 fingers here, and you elevate the urethra as such, just as the 2 fingers are shown in this picture. And then you push over the urethra to isolate this area in order to place stitches, which you see 1 here, 2 there. Those are 2 future placements of a stitch. Here's a total of 4 after the surgery. In addition, lateral defects in the pelvic floor of laxity can be repaired, such as a perivaginal repair for perivaginal defects. You can place stitches in this area too and stitch down in order to elevate and repair the pelvic floor a little more proximal than the area of where a birch or urethropexy would occur. So all of this area is involved in this surgery here in order to suspend the floor. This was popular through the late 90s, and basically this type of surgery was continued to be done, and is continued to be done today, but less in popularity. A urethral sling procedure, or a pubovaginal sling, was a surgery that was done in a retropubic approach, where a surgeon went down in this area and actually dissected, took a Kelly and split through this area of fascia and placed a sling all the way around this area. This was not an artificial sling. This was either harvested from the patient or it was donor fascia. And this was very popular in the late 90s. And that would also go around here and you would tighten it up to the rectus fascia and hold up this area. That's a pubovaginal sling. And later we saw the mid-urethral sling made with polypropylene mesh. So basically this is a cross section that I'm going to show you here. if you were to take this pelvis and cut out a section and lay it up on this picture, or another way to look at it is you would cut right through here and you'd lay it up on this picture, seeing a cross section of these surgical areas. Basically, this is the fascia tissue called the obturator internus. This is the popular endopelvic fascia out here, and the the urethropelvic ligament, or the pubocervical fascia. They all are somewhat continuous in this area. For the sake of this argument in demonstration, we're going to call this the urethropelvic ligament, and this is the urethra. This is the arcus tendinus. Again, this is cross section right through here, arcus tendinus, obturator internus, urethra. And this is the vagina right underneath. Vagina lives right in here, and you urinate right underneath the pubic bone. So anyway, this is giving a demonstration of the proximity of the vagina and underneath the urethra and the ligaments out all the way out to the arcus tendinus. Now here in this picture is the popular mid-urethral slings that were done over the last 15 years, probably about 90% of the time, for stress incontinence. And basically, these are done with trocar devices hooked to a sling material. This is the standard anatomy. You go through the vagina with some scissors, you isolate this area, open it, go underneath the urethra, and perforate fascia this way. So you perforate this urethropelvic ligament and also this rectus fascia, and you would pull up. You would pull up.
To just make sure again.
Basically, this is another one. It's called a transobturator sling, and this was done through the vagina as well. You cut through here and you run the sling this way, and you pull it. So these are slings, suburethral. They go under the urethra and pull up with certain forces. An example of this is the transobturator, which would basically, much more commonly done nowadays, it perforates right through the obturator canal, comes right behind the pubic bone, and out through this area right here. You do the same on the other side, and your sling would travel through here. And that's a transobturator. And so basically there's very little space here, but that small mesh sling could fit under here and perforate through these fascial planes in order to anchor it in place and to prevent hypermobility. When these fail, or the patient had sustained multiple surgeries and loss of tissue and had a more severe incontinence, an artificial urinary sphincter device can be placed here. This again is the vagina, and this is an artificial urinary sphincter. This is a more substantial surgery, which had a lot of complications. It's not FDA approved, but it works better in men. Regardless, a cuff is placed surgically down in this area. You place it circumferentially around the urethra, and you're able to inflate into this inflated position to squeeze in on the urethra. Now this is more bulky. That's the problem with this device, is in order to occlude the urethra, this is a very bulky area, and you are prone to get infections, erosion through the vagina, and this is well reported in the literature, which is one of the reasons why it's not FDA approved. Again, that's the artificial urinary sphincter, a cross section of where it would sit in the pelvis. My proposed implant, or a new treatment option for lateral defects of the pelvis as well as incontinence, would be to place an implant on top of this entire plane without ever perforating, and you basically restore continuity of this entire area all the way out to here, and all the way out to here. You could repair defects and then lay an implant on top of it to reinforce, such as this. And this picture here shows how the implant would work. You would lay the implant there. You could place your 4 sutures just like you would for a Burt's urethropexy. You could do lateral defect repairs. You could incorporate them within this artificial material in order to reinforce this entire area to keep this from having hypermobility, and plus create a continuous plane in what I would call a backboard, which is important later. So a cross section of this would be this. This again is our cross section, just as we see in these other areas: urethra, urethropelvic ligament, and the obturator internus is way out here, and that's in this picture right here. And basically you would lay this here, placing tacking points to keep all this in place, and such as here. These, what all these little things are here, this would lay here like this, and you would tack it down with little needles and sutures. These are not trocars. And basically underneath this device is an expandable member. So underneath this device, which would push posterior, is an expandable member, not shown on this diagram here. But basically shown as a thin line here. This is the deflated position. But if you place this into the pelvis, creating a fixed plane of support, continuity of all these fascial planes together, repairs, reduction, just like you would repair a hernia. And then basically if you were to inflate this member, you would press down on the urethra, providing closure and preventing incontinence. Why would you do this, and why would I recommend such a thing? You would never have to do any type of bulky implantation underneath the urethra. You would never place a foreign body here. Plus you can mostly avoid this area, or 100% or partly. You have the option of placing an optional graft underneath here that is about the size of this piece of this element here, that basically can be placed through the vagina if wished, in order to place sutures through the implant all the way down to a piece of donor tissue or some sort of bioabsorbable material here and here. And it basically would be on the opposite side of this area, on the vaginal side, underneath the urethra, in order to create a clamshell space, I call it. Create a confined space, so that make it even more likely for an expandable member here to occlude the urethra as it expands. In the pelvis here that we have, this would lay in here as such, like this. The surgeon has several options. You can basically repair any of these lateral defects first, or you can basically reduce it, and while it's reduced with a finger or some other agent within the vagina, you can lay this on there and tack it down with fine instruments or deploying devices with a robot and lay this in the pelvis as such. Once the surgeon has all this reduced, keeping this a fixed plane, they can then work on the expandable member, which is underneath the implant but on top of the urethra, in order to expand posteriorly. Another transvaginal surgeon can be in this area with a pair of scissors, making a small incision, placing this opposing graft if they feel necessary. And basically at the end of the case, the surgeon can decide to cut this off, this extra material, or stitch it to Cooper's ligament or out to the operator internus, and more importantly, make sure it's affixed to the arcus tendinus out here laterally to restore all this anatomy into its appropriate position. Thank you.